So we'll start immediately with Dr. Ankur Sinha, who's going to talk on how to approach esotropia. So it'll be comitant strabismus for a couple, then restrictive and paralytic strabismus, and then finally a VAST where we'll go through the various kind of surgical steps. So welcome everybody.
Thank you, Rohit sir, and thank you, AIOS, for giving me this opportunity. I'll be talking in brief about how to approach a case of esotropia. So all strabismus approaches, we start with history. So history as an age of onset, the laterality, the intermittent or constancy of the squint, they all tell us about the type of esotropia and the probable issues associated with the esotropia. The birth, neonatal, developmental history, and the associated neurological issues, because then we can have association of a developmental delay, which can have difficulty in managing the strabismus. Check for the head posture, because cross fixation, oblique dysfunction, associated nystagmus can have these head postures along with the esotropias. And also look out for things like ESO-DRS, which are not typical esotropias, and they may have different kind of management than routine esotropias. So do a cover and cover test, always kind of find out whether it's a true or a pseudo esotropia. In this child, we can see that the lateral sclera are more shown as compared to the nasal sclera because of the broad nasal bridge. So this is a pseudo esotropia. And this girl also looks like to have an esotrope. But then once we do the cover and cover test, we can actually see that the eyes are coming in. So this is actually an exophoria and looking like a pseudo esotropia. So it's not a surgery because she came for a surgery for esotropia and she has an exophoria. So you can't operate these patients because they do not have actually, they squint and you do something, they'll land up with diplopia. So ocular movement should be checked. Like this girl, we can clearly see that the left eye is up and inside. So it's an esotropia with significant inferior oblique overactions. In this case, we can see there is one minus abduction of both the eyes. So probably it's not a simple esotropia. Now in this child, we can see the child does have a left esotropia, but when you look carefully, ask the patient to move right and left, you can see that the eye does go up. So it's a case of esotropia with inferior oblique overactions, both eyes. We can see in both the eyes when they go up and above. Refractive error is to be checked. Like this is a small child. Whenever you show a toy to this child, the child has an esotropia, and all what is required is to give him proper glasses even at this age. In this case, we can see that the esotropia is partially corrected from say 30 prism diopters to approximately 15 prism diopters. So it's a case of partially accommodative esotropia. And in this case, there is no effect of glasses. So this is probably an infantile esotropia, and we will have to plan this patient to manage this patient surgically. Whenever we prescribe glasses, always check for the fitting and the usage, because this child is looking over the glasses, and whenever the child is looking over the glasses, the child also has an esotropia. Another case where the glasses are tilted and kind of distorted. So the distorted glasses does not allow the child to be kind of seeing properly. Once you make them right, the child is able to see clearly through the glasses. Fundus and neurological examination is important because this is the case which I showed you before, had a bilateral limitation of lateral movements of both the eyes. So this case has a papilledema, and the cause here is intracranial space occupying lesion. So the 6 nerves can present like an esotropia, and they can have severe life-threatening issues along with it. So esotropias could be comitant or incomitant. The comitant ones can be accommodative and non-accommodative. Accommodative could be a refractive accommodative, non-refractive accommodative, partially accommodative or hypoaccommodative. And non-accommodative can be either infantile esotropia, basic, acute onset, cyclic, or non-accommodative convergence excess. Incompetent can have paralysis, paralytic squints, and restrictive strabismus, and they have to be dealt separately, not like a typical esotropia. Now, infantile esotropia, we approach with a full refraction, whether it's an atropine or a hometropine or cyclopentolate, whatever you want to use, and try and prescribe the full correction, because you want to see how the patient does with the glasses in terms of BCVA and deviation. And then also note the associated movement abnormalities like the DVD, obliques. The child can have Chiantia or the Lang syndrome. And then occlusion or the amblyopia therapy has to be instituted, because some of the esotropes can develop amblyopia, although it is rare to have amblyopia with the infantile esotropia because most of them are cross fixators. And the management here is surgical. So approach, we have discussed now, how do we plan for a surgery? So counsel the patients that almost all infantile esotropes would need a surgery, and sooner the better. There's a controversy trying to operate little less than 4 months of age, but if you do earlier, they do develop some amount of binocularity and limited stereopsis also. Plan symmetrical surgery whenever we're trying to do the surgeries, and tackle the obliques also if they are present. And do remember that the small children tend to respond more as compared to adults, so adjust your dosage accordingly. Now this is another case of infantile esotrope managed surgically. Accommodative esotropia, usual onset is about 1 to 3 years. It may be intermittent to begin with, and the child would be a neurologically normal child. The approach here again would be to do a proper refraction and give full cycloplegic correction. And usually the child gets full correction in case of fully accommodative esotropia. So do assess the vision and deviation with the glasses, and if required, amblyopia therapy may be required. The child is having amblyopia. Now then you can have refractive accommodative esotropias with high AC by A ratio. So these patients would have esotropia because of uncorrected hyperopia, and the near deviation would be more than the distance deviation by a factor of 15 prism diopters. Approach here again would be to do an atropian refraction and give a full cycloplegic correction. I usually begin with giving +3 at the beginning, and then we can try and wean off. The importance here is to give executive bifocals. They actually should be bisecting the pupil, or at least should be the lower border of the pupil. Again, reassess the deviation and the vision with glasses, and if the child has an amblyopia, this has to be treated upon. Now, partially accommodative esotropia, it is characterized by partial correction with glasses. So this is a girl who is having 30 prism diopters without glasses and 15 with glasses. And this is the 9 gazes. We do not have any other abnormalities here. So the child undergoes one medial rectus recession, and the child is absolutely aligned in this case. Now, acute comitant esotropia, it's a sudden onset of esotropia beyond infancy or after infancy. And there's a definite increase in these kind of cases, definitely after the pandemic. And there could be, commonly the 3 types, the Swan, Burian-Franchetti, or the Belchowski's type. And sometimes you do have acute comitant esotropia associated with the intracranial pathologies. So they are to be kind of investigated if you're not filling into the typical group. So approach here would be an atropine and homotropic refraction. Usually doesn't help. Neuroimaging in suspects whenever you have disc edema or any suspicion of having neurological defects, and in the older patients who present with acute comitant esotropia, surgery usually is the answer. This is a 14-year-old boy with the acute comitant esotropia managed surgically. Now, this is another case where we have an older patient who is presenting to you with acute comitant esotropia with gait abnormalities and difficulty in walking. The neuroimaging shows a herniation of cerebellar peduncles into the brain. So to conclude, a proper workup establishing the type of diagnosis of the esotropia, it is a must for a good outcome in these patients. Thank you.
Thank you, Dr. Ankur, for comprehensively covering esotropias. You can just come and join me in the dais. We'll take the next talk on intermittent divergent strabismus, and maybe take a bit of brief discussion on the comitant strabismus post that. Dr. Ankur has very clearly talked about how an esotropia has to be approached. Whenever first time, check for the deviation, check for vision. So manage refraction, ensure an age-appropriate cycloplegic refraction is done so that you eliminate accommodative esotropia. You check for the vision, ensure that if there is amblyopia, that needs to be treated, and according to your diagnosis, you need to manage it. And of course, before that, you have to divide that into comitant and incomitant and manage appropriately. So we'll go on to intermittent divergent squint. Probably increasing, I think, in our population. We're seeing far more divergent than convergent. We were seeing convergence much on a greater amount in children, but now we are seeing a lot more divergent strabismus. Possibly myopization is a factor, but we're definitely seeing a lot more. And actually, intermittent divergent squint is a bigger nightmare, I would say, to manage. Feels simpler, but is actually tougher considering the